everyone. Happy New Year. Hello. Can you all hear me? I hope so. So we're starting this new year in 2023 with a really interesting topic, right? And first of all, I'm going to apologize. I'm not Dr. Sesobo. My name is Dr. Chichi. Unfortunately, Dr. Sesobo could not join us this evening because she's a little bit under the weather. It's flu season. She's not feeling very well, and we've had to step in for her. So today we're actually going to talk about a topic that causes blindness in a lot of people, and is actually said to be irreversible blindness, and that's glaucoma. And what's really shocking is that when we looked at the data surrounding glaucoma in places like the United States, at least 3 million people are affected by glaucoma every year. That's really stressful, I think. I think that's really like a huge number. And today we're really lucky because joining us today, okay, that's Dr. Sosoba, as I said before, is a leading consultant that looks after people that have glaucoma issues. And I just wanted to share a bit about the work that he's done because it's quite significant. And I think it's good to understand that when we come onto the sessions, we want the people that know what they're doing to speak to us, not just anyone. So with us today is Dr. Walker, and we've been really lucky that Dr. Walker has been introduced to us by the Moorfield Eye Hospital in Dubai. They're our partners in this, and they're supporting us for this episode. And as you know, Moorfield is like #1 for eye care in the whole world. I can say that easily, all the way from London to Dubai. And they've also, I believe, have a center also in Abu Dhabi. So if you were thinking that your eyes are not that great, that's where you should really be going to. So we really want to thank Moorfield Dubai for their help today and like sharing this amazing consultant with us who's going to speak to us this evening. And more importantly, I also want to thank my entire team, the animal health team, for always standing by us to try and get the sessions going. Sometimes they're really a little bit really difficult to get it off the ground, especially in the evenings. And today everyone's coming like an hour earlier than we normally do, and they're still giving their time over and over again. So thank you so much to Moorfields, and thank you to my entire team. Now I was going to introduce you guys to our speaker. So Dr. Walker graduated in Pakistan and has 15 years experience working in the United States. He's worked in really prestigious places like the West England Eye Hospital, in Exeter, in Northfields, and also in the Medical Eye Clinic and the New Medica. And obviously he works in Moorfields, Moorfields, Dubai at the moment. His expertise is actually treatment of glaucoma using both laser and surgical treatment, and also medical treatment. I put it 2 times just to reinforce what he does, right? It's not just normal glaucoma, but he does things that are minimally invasive implants and also does a lot of like shunts. He's also known for his expertise in things like small incision technology, which is really big. And also what's really interesting is that he does a lot of like tailored patient care in an individual, just to address people's individual needs. In terms of his knowledge of technology, which is what's redefining the whole of medicine, he offers again, as I said before, small incision technology. He does a lot of things with multifocal and extended depth of field. And more importantly, Dr. Walker is really actively involved in research. And what I really like when I read about his profile, and that's what I'm sharing it with everyone today, is that he optimizes patient outcomes. And that's really important because he's not just going to treat you as just a number, but actually as an individual. He's written a lot of peer-reviewed journals, and he's also a member in the United Kingdom, in the United States, and also in Europe when it comes to ophthalmology. And what's really great as doctors, and like I would say, is that it's not just okay to just be great, but if you're great and you're training the next generation of doctors, then you're really great. And it's really great that this gentleman has been nominated as a regional trainer in the UK for ophthalmology. And also he's written so many research grants, co-authored a lot of books. And I think the most amazing thing about him is, despite the fact that he's just a guru when it comes to eye care, he also is an avid reader, an aspiring author, and a motivated triathlete, which is like, he's going to tell us a little bit about this when we go into like talking about glaucoma. So welcome to us today is Dr. Walker. Thanks for joining us.
Thank you so much. And thank you so much for the very kind introduction as well. Very grateful to be here and very grateful to you all for taking time out of your busy schedules to join us today as well.
Thank you so much, Dr. Walker. So I thought that maybe what we should start out with is actually start out with something a little bit interesting, which is, I know I've said a little bit about you, right? Which obviously I've had to research to get to it, but I think it's also good for you to like tell us a little bit about yourself when it's not just us reading like a whole journal of like stuff about you. What's it like on a day-to-day as an ophthalmologist?
Oh, ophthalmology is a very interesting career. Obviously, we graduate from medical school, just like all our other medical colleagues. And then we go through quite a rigorous training program, can vary from between 5 years to 7 to 8 years, depending on which country you're in. In the UK, it takes about 7 to 8 years. And then you do a fellowship in the area of subspecialization that you want to go into. And even though the eye is a small organ, of course, there are a lot of subspecialties within ophthalmology. There's about 7 different subspecialties. And then we kind of work our way into those subspecialties and then specialize in those areas. So my area of expertise really is cataracts and glaucoma and the more complicated surgeries and treatment decisions that go with that. And then so I did my training from the UK, worked for a long time in the UK as well, and then eventually found myself working with Moorfields as an extension of Moorfields London, working at Moorfields here in Dubai.
Wow, interesting. That's a really interesting career. So you've been to like the almighty, like eye care in the UK is like close to nothing, and now you're in Dubai. That's really nice, right? And I noticed you've done a little bit of work, like you're also part of the academy in the US also, isn't it? Was that like the same practice or a little bit different?
Absolutely. So one of the great things about ophthalmology is that we collaborate very closely with colleagues, not only on mainland Europe, but also in North America, in the US and in Canada as well. And so we do have transfer programs. We go around and we observe how our colleagues are doing things. And by and large, practices are very similar. There may be some regional differences in the choice of treatment techniques and treatment algorithms and treatment decisions sort of pathways. But by and large, everybody wants to make sure that their patients are well looked after. Everybody's treatment decisions are evidence-based these days. We share a lot of research and at the end of the day, we all individualize our treatment options for our individual patients. And that really is the keystone of our practices these days.
Okay, thank you so much. So I just want to thank everyone that's joined so far. And just a bit of a recap. If you have questions at all, this is like your great opportunity to speak to like a guru when it comes to glaucoma care, right? So it could be yourself that needs like a question answering, or someone that you know that really wants to hear like from the best. And I think this is an opportunity to like ask your question. So you put it down in the chat and we will at some point just ask Dr. Waka. We're like so blessed to have him here. So I'm excited. So let's just try and get him like telling us stuff that we need to know. So Dr. Waka, I'm not letting you go because I want to start out with saying, please, what is glaucoma, right? Like, this is like a word I've heard since I was like a child. And when you say to someone, I've got glaucoma, they're all like panicking, like, trying to find help from the best place. What exactly is glaucoma?
So glaucoma, in the simplest words, basically means that you've got high pressure in the eye. We all have a certain amount of pressure in the eye, very similar to blood pressure, but different from it. The two are not related. The eye pressure is also known as intraocular pressure. And all it does really is that, our eyes are basically a sphere, a globe. And the reason it doesn't collapse on itself and become, all squishy and soft and shrinks is because there's an internal pressure that keeps the consistency of the eyeball as it should be. And that keeps all the structures within the eyeball healthy. And that is what eye pressure is. That's what intraocular pressure is. And there's a certain value within which it's healthy for it to remain at. But if it goes high, then that is what is known as glaucoma. Because when the pressure is high, the nerve at the back of our eye that connects our eye to the brain starts to get compressed, starts to get damaged, and that starts to lead to gradual visual loss, which in turn, in time, can lead to complete blindness as well. And this is, in a nutshell, is what glaucoma is.
Okay, thank you. So it's like blood pressure. We all know that blood pressure is never good, but it's now blood pressure in the eyes, right? And I was just wondering, like how we get told that, hypertension, that we have to avoid this, avoid that, avoid that. Is there like risk factors that predisposes people to like glaucoma?
So that is a great question. So there are different types of glaucoma, but by and large, the commonest type of glaucoma is something known as open angle glaucoma. And to be honest, there's nothing that you would do to cause it, and there's nothing that one could do to prevent it. It's one of those things that just, a person's body is predisposed to it, whereas somebody else's isn't. And then the key to it really is to have regular eye examinations. If you're having regular eye checks annually, sort of after the age of 20, every 2 years, after the age of 40, every year, particularly if you have a family history of glaucoma, one of your blood relatives, if they have glaucoma, then you should make sure you have your eyes checked regularly, and not just an eyesight check, but actually to see an eye specialist and ophthalmologist to make sure that your eye pressure is checked, that they look at the nerve at the back of your eye. It's a quick little thing to do, but if you do this regularly, then any eye pressure changes, any nerve changes would be picked up on time. And then proper treatment can be given to prevent any damage long term. But in essence, there is nothing that you would do by and large to cause it, or anything that you could do to prevent it. So I often tell my patients, carry on with your life, enjoy your life as you normally would. Of course, have healthy lifestyles. So if you have a healthy diet, if you take good care of your health in terms of not smoking, getting regular exercise, then that not only helps your body otherwise, but also helps prevent glaucoma as well.
So it's like when you said something about, having regular eye checks, what came to my mind is that, we do regular checks for our cars. We change the oil, we look at the oil filter, we look at like the petrol filter, but nobody ever thinks about health in that way. Like you should really be checking your health every year. So you're saying from this message that if we looked at our eyes every year, for example, I know you said different times for different ages, and we make sure that the pressure was right, then we are able to prevent it from taking us all the way to blindness, isn't it? That's what we're trying to prevent, I think.
Absolutely. And so the number of people who go blind from glaucoma, if it's adequately treated, is very, very low. Less than 1% of people who may have very severe, intractable, difficult to treat glaucoma, where even when we're trying our best, we can't get on top of it. The percentage of people going blind from glaucoma when they're under good treatment is very low. But if it is not diagnosed on time, let's say I wasn't having regular eye checks and I had glaucoma and I discovered it 10 years later, then it's already too late. But if it's picked up one time, then with adequate treatment, the chances of suffering severe damage to your vision is very, very low. There are a whole lot of treatment options, and I'm sure we'll discuss that as we go along, that we can go through to protect and preserve vision.
Okay. And then you talked about, we talked about blindness, right? And I was going to ask a question, I guess, like, maybe that's what people would really want to know, is we talked about the fact that glaucoma could cause blindness, right? And I assume there's reversible blindness and there's irreversible blindness. Like when we had the talk on cataract, they said to us, even though you're blinded by cataract, once the cataract is surgery happens and your lenses change, you just start seeing. Like, it's like magic, like, you have like a miracle happen and your eyes are better. Does glaucoma work that way, or once you're blind from glaucoma, does it?
Well, that is the big point, that once you are blind from glaucoma, which means that basically the optic nerve, the nerve that connects your eye to the brain, has been damaged. And as you know, there is no known technology or treatment at present that can regenerate nerve cells. And so once that damage has happened, unfortunately, that's it. So that's a really good point, that unlike other causes, such as, for example, if you have a corneal pathology at the front of the eye, you have a corneal transplant, you can restore your vision. If you have a cataract, you get the cataract removed, you can restore your vision. But with glaucoma, if the damage is done, then it's hard to reverse it. Any treatment thereafter would be aimed at stabilizing the condition. And that is exactly why early detection and early treatment is the most important thing with glaucoma.
Okay, so I think what I hear is early detection, get your eye screened, and just try and get it done on time. Like put your pressure better, get your lifestyle right, and then hopefully your eyes will be okay, right?
Absolutely. If, like I said, if it's diagnosed on time, there's really no reason why anybody would suffer any visual damage in their lifetime.
And then we talked about risk factors as being like if there's a family history of glaucoma, but you also mentioned something that I missed, but I was going to go back to. You said there are different types of glaucoma. Can you cast a little bit of light on that? Like,
absolutely. So to describe it in simple terms, there's two types of glaucoma. One, what we call as open angle glaucoma, and the other what we know is called as closed angle glaucoma. And what it generally means is that in the eye, broadly speaking, there's a muscle that makes a fluid, and there's a drainage system that drains that fluid away. And it is the balance between these two, the production and the outflow, that keeps a certain value of pressure in the eye. And what happens in glaucoma generally is that the outflow system can get blocked, either because intrinsically it's not working as well as it should, which is a form of open angle glaucoma, or something is covering it in the eye, which is a form of closed angle glaucoma. And depending on the type of glaucoma, we would then customize the treatment options, because the different types of glaucoma require different kind of treatment options, whether it's laser or surgical or eye drops. And also sometimes there can be other conditions, such as if someone has a bit of inflammation in the eye, or if you've got really bad diabetes, you've got what we call as neovascular glaucoma, abnormal blood vessels forming in the eye that can cause glaucoma as well. But these are less common forms of glaucoma. So it really depends what kind of glaucoma is. By and large, the commonest type is open angle glaucoma, but there's a lot of advancement now in the treatment options. In fact, there's been an explosion of really quite minimally invasive and easy to recover from treatment options over the last 10 years. And in fact, glaucoma within ophthalmology is one of the fields that's advancing the most rapidly over the last 10 years or so. And so there are a lot of options that we can tailor and customize to each patient.
Okay. And I think when we were trying to collect questions about what people wanted to know about, someone asked is there a noticeable difference in prevalence in like where people, in terms of people's sexes, whether you're male or female, whether you're young or old, or whether any type of job that you do that could predispose. I know you said they're not really risk factors, you either get it or you don't get it, but is there anything that predisposes people to the pressure thing in the eye and then that brings it on?
So there is no difference between genders. There is a difference between the types of glaucoma in different regions. For example, glaucoma related to diabetes is far more common in Africa than elsewhere. And I think that's a reflection of the fact that screening for diabetes is not as widespread as it may be in European or North American countries. And then there are the different kinds of inflammatory conditions that are more common, for example, in Oriental populations, and therefore glaucoma associated with that can be more common there. With regards to age, generally, it's more common in older age. So countries around the world, particularly in North America and Europe, that have very high numbers of elderly populations tend to see more open-angle glaucoma. It's something that tends to come on mostly after the age of 50. In fact, some babies can be born with glaucoma as well, something known as congenital glaucoma. And sometimes young adults, sort of between the age of 8 to 20-ish, can also develop glaucoma, something known as juvenile glaucoma as well. But these are far less common. And by and large, it's simply a manifestation of age.
Okay, thanks. So I was just going to ask, let's assume, like, I know we've said that what's really important for people that are just joining is that doing a regular eye check, making sure your pressure's done, making sure you're eating right, making sure you're like living a nice lifestyle, like no smoking, not expecting your pressure to be too high. But I was just wondering, let's assume someone is like oblivious and hasn't attended today, right? And they've just not checked their eyes at all. And they've just thought, my eyes are always going to be okay. I can see properly. Is there some symptoms that people notice? And then because of that, they should really be thinking, oh, it could be glaucoma. I need to go get myself checked out. I'm just wondering if there's
Yes, this is very important to be aware of. So with open angle glaucoma, the pressure goes up very slowly. So you tend not to get any symptoms at all. In fact, that is exactly why screening is very important. And by the time you notice kind of a restriction of your peripheral field of vision, it's already too late. And then really the disease needed to be stopped many years before. So that's why regular checks are very important. And this is for open angle glaucoma. If someone has angle closure glaucoma, then there is a kind of angle closure glaucoma known as acute angle closure glaucoma, where the pressure just goes up very suddenly. And I haven't mentioned this before. Normal pressure is between 6 to 21 millimeters of mercury, which is how we measure it. But in acute angle closure glaucoma, the pressure can go up as high as 50, 60, 70 very suddenly. And this is a true kind of ophthalmic emergency. And with this, you would have nausea, vomiting, red eye, a sudden decrease in vision in the eye, severe headache, severe eye pain. It's really not something that anybody would be able to miss. And by and large, people would then go along to their local emergency department, and then they would contact the ophthalmologist to come and have a check, and you'd find that the pressure is very high. And then with some medications and some laser treatments, that can be controlled. So that's going to be very obvious, and it's going to be hard to miss. But if you have regular screening checks, then the other varieties of glaucoma can be picked up. And really, you want it picked up before you've noticed any symptoms at all yourself.
Okay. You talked about peripheral vision. What do you mean by peripheral vision? I think that's...
Absolutely. So basically, our vision is composed of two parts. One is our central vision. So when I'm looking at the screen, when I'm looking at you, I'm using my central vision. And then as I'm looking at you, I'm also aware of what's happening around me. And that's my peripheral vision. So the central vision is very fine. This is what helps us to read and identify a very, very precise detail, whereas the peripheral vision helps us to navigate. I'm aware of my hand side because of my peripheral vision. I'm aware of the lamp on the side of the table because of the peripheral vision. And this is not precise vision, but it's very important for our day-to-day activities. And so what happens in glaucoma is that the peripheral vision starts to constrict. So you don't notice it at first, but eventually it starts to become like a tunnel, as if you're looking through a tunnel. And by that time, your peripheral vision is restricted a lot. So once you still have central vision, and in effect, you might measure your vision and you might find that a person's vision is 20/20 or 6/6, as we call it, which means normal vision. But if a car is coming from the side or somebody's moving in from the side, they won't be able to see it. So for their daily activities, if they're going downstairs, they won't be able to make out where their feet are, because that's a function of our peripheral vision. And this is the thing that gets affected in glaucoma. And eventually, if glaucoma is untreated, then the whole vision just goes away. So the peripheral vision is very important for our daily activities, gets affected in glaucoma, and that's the loss that we want to prevent by controlling the pressure.
That must be really scary, isn't it? Because that literally means, because they can't see things on the side, they're like constantly, like as you described it so nicely, in a tunnel. It's like you're in a tunnel, like walking around, and then everything else you can see. That must be really scary for people. And that's why, obviously, as you've said from the beginning of this talk, is that it's eye check, right? The same way you check your car, you check things, you check your lock, you should be checking constantly, I think. That's the message I'm getting. And I think we should like dive into, what do we do? Let's assume someone's got, I guess there's like a broad spectrum of things that can be done for glaucoma, because from what we've talked about, like if people like get it on time, I guess they have more options than if you get it when it's really bad. So I'm just wondering, what are like the variety of things that can be done if it goes wrong?
So if it's picked up, let's start from, it's been picked up early. So somebody's come into clinic and we find that they've got early glaucoma. They haven't noticed any change in their vision at all. Pressure's a little bit high and all the tests are normal. Then all that they require will be just an eye drop to use. Usually it's an eye drop, you put it in at night before you go to bed. And you have to use it pretty much for the rest of your life, very similar to how you take blood pressure tablets, for example. But that will just control the pressure and your vision is protected long term. Of course, this will be supplemented by regular eye checks to make sure that the pressure stays okay. Usually you'd have it checked again. You'd have your eyes checked every 6 months or every year, and that will carry on for the rest of your life. Now, if that drop doesn't control the pressure, then there are 3 or 4 different kinds of drops that can be added on. Of course, that has an impact on quality of life. You don't want to be using drops all the time. And we try and minimize it as much as possible, but these options are available. Now, more recently, we also have some laser treatments available as well that have about an 80% chance that they can control the pressure without the need for drops. So that can improve the quality of life whilst also protecting from glaucoma as well. But there's a 20% chance that you still may need to use drops as well. Now, if we move on to moderate or advanced glaucoma, where by the time it's diagnosed, already there is some peripheral vision loss, the nerves is looking damaged, the pressure is high, it's not controlled, and we've tried a few drops, but still the pressure is out of control. Then we move on into surgical options. And in surgically speaking, there used to be some big operations that we used to have, and that was the only option on the table. But now we have these minimally invasive treatment options, as we call them, minimally invasive glaucoma surgeries, and even aqueous shunt devices where we can put little stents and tubes in the eyes, which are so small that if you were to put them on the tip of your finger, you won't be able to see them. Oh. In fact, they're one of the smallest devices implanted in the human body anywhere. And so that kind of gives you an idea of the precision and the delicacy involved in that. And also, once they're in the eye, you don't see them at all either. You could look in the mirror yourself, you wouldn't see them, but they're working away in the background, and they will just help to drain that excess fluid away and control the pressure. So all these treatment options are much, much safer now. Of course, all procedures, all medications carry some risk, but the risk is very low, less than 1%, and 99% of the time they work very well. So with all of these things, it's very seldom that we're unable to control the pressure. If it's diagnosed and if we have regular follow-ups and good compliance to treatment, then 99.9% of the time we will control the pressure and protect the vision.
I think a risk of like 1% compared to 3 million people every year going blind from glaucoma is like, I'd rather take the risk if it's me, because it's such a small risk, right? Compared to, imagine if like you were one of that 3 million in the US alone. I can imagine what the numbers are like in the UK, in places like Africa. It's going to be like really huge, where there's like a lot of like diabetes and every other thing going on, right? So I was just thinking, I know you talked about this implantable devices. So they do the same thing as if you said they're really tiny and they help the drainage. And that sounds like new magic or something, like minimally invasive. And I guess you need a special skill to be able to do that. Is that how it works?
That's true, of course. I mean, you know, like as with anything else, really, if you're having anything installed in your home, or you have a pilot flying a plane that you're sat on, or you have a surgeon operating on your eye, you want to know that the person is trained to get that job done. So similarly, of course, we go through training for these things and get certifications and all that. And of course, you want a surgeon who's specialized in these things. And these stents and these equation devices, they are very specialized. So like I said, ophthalmology has very, 7 different subspecialties, and we don't all do all the procedures. We're all specialized in different things. And the glaucoma specialists are the one, of course, who can manage these kind of devices and procedures. Absolutely.
Oh, thank you. I was just thinking for everyone else that's joined, just a little bit of recap. We've been talking about glaucoma, which is like the leading cause of blindness in the world, to be honest, right? And then we talked to Dr. Waka, who is like a world-renowned ophthalmologist that does not just minimally invasive, right, surgery, but also is a world specialist for glaucoma care. And he's joining us from Moorfields, Dubai, which is really great. And I think we're going to keep, I'm going to keep my questions, but then I have a few questions in the chat box from people that have joined us. And just to recap, if you have any questions yourself, please kindly just put it in the chat box, and then we can ask Dr. Waka ourselves, because we're really lucky today that he's come all the way from Dubai. I haven't asked you what time it is in Dubai, but I'm just going to keep quiet, because I know I'm sure you've been at work the whole day, and then now you're listening to me chat away and just like answer questions. Thank you so much, Dr. Walker. And thanks to the Moorfields also. It's a really great day. So the question is there a genetic link to glaucoma? I think we talked about it a little bit. My father was partially blinded by the condition, so I'm a bit worried right now about myself. What should I be doing? Nice question, I think.
So there can be a genetic predisposition, but the good news is that it's a small percentage of people. So if somebody in your family have glaucoma, you have a 25% chance roughly that you could develop glaucoma, but equally you have a 75% chance that you might not. So the odds are in your favor that you wouldn't, but at the same time, 25% is not a small percentage, and that's why we recommend that, particularly if you have a family history of glaucoma, you must have your eyes checked every year. Now, with regards to your family member, if they have lost vision from glaucoma, there could be a variety of reasons. The most common reason being that perhaps it was not diagnosed on time and the damage was already done before the treatment started. So now we're in the situation where, with more awareness, particularly through initiatives as this one, and I think you guys are doing a great job with this, is basically that if it's picked up on time, then the risk that you would suffer damage to vision is very, very low. So I think you should be confident that, by having your eyes checked at least once a year, the risk of anything happening to your vision is very low.
Okay, thank you. I think you're really right about, the awareness thing. I think we need to create more awareness for people to understand what they should be doing with their health. I think a lot of us don't really know like what we need to do. We think about other things, but the basic thing, which is health, that makes the substance of us, we never think about taking care of it because we're so busy rushing from one point to the other. So I think that's a really like raising awareness. And I guess what I'm going to say to people that have joined today, it's nice to like share the news with someone and say, listen, have you got your eyes checked? You should check your eyes, check your eye pressure, because you've learned something today from like someone that knows what he's talking about. And I think that's my own take on message. And I guess we'll share every other person's take on message later. So as I said before, if you have questions, please kindly just drop us so that Dr. Waka can answer your questions. And Waka, I was going to go to the next question. I know we talked about like when people have like mild type of glaucoma, and we talked about the moderate type, but we haven't talked about people that come to you because they become blind from glaucoma. What happens? What's their options at that point? And is there any advancement in those people?
So when somebody's already got advanced glaucoma, that's a difficult situation because, as I said, it's not possible to reverse the damage that's already done. But what we can do is take a lot of steps. Usually it ends up being some sort of surgical treatment with the kind of options that we discussed to try and stabilize the condition. Now, often I've seen that somebody in that situation may not have had their eyes checked, which is why the glaucoma became advanced. So they may also have a cataract as well. So then at the same time as doing the glaucoma procedure, we can also remove the cataract, and that can restore some element of vision, which is always very, very nice to see. But of course, whatever damage is present from the glaucoma, we can't reverse that. Now, that being said, also there is now this kind of field of neuroprotection, which basically means that how we talk about free radicals and free oxygen radicals affecting the rest of our body. Similarly, they can affect the optic nerve as well. So there are some medications, there are also some herbal medications that can be taken to offer neuroprotection to the optic nerve. So these are new areas that are being explored to try and regenerate the function of the optic nerve and to try and understand if an improvement can be brought about. But I think there is still research happening on this, and time will tell. But if it's very advanced glaucoma, then what we can do is stabilize the vision, look at other reasons for visual loss, which are reversible, try and address them, and try and get the person back to a functional state within society. But the key really is to prevent it from getting to that stage in the first place.
Mm-hmm. I think what we've had throughout this talk is prevention, right? But then I was going to say something. You mentioned that glaucoma can also happen at the same time as cataracts. Are there other eye conditions that could also happen at the same time as glaucoma that commonly seen with glaucoma? And I'm just wondering. And do you think
Yes, absolutely.
two or something, or the three that happen together? Who knows? Like combination stuff.
Yes, no, absolutely. And that's sort of something that I often deal with, these complex cases where a lot of things are happening at the same time. Things that can overlap quite frequently, in fact, are inflammation. So if somebody has what we call uveitis or inflammatory conditions in the eye, not only do you have inflammation, the inflammation can cause cataract and glaucoma. So all three things happening at the same time. And then we would work together with our uveitis colleagues to try and address that all together at the same time. Other conditions that are often seen with glaucoma are things like vascular occlusions in the retina, so retinal vein occlusion, for example, or advanced diabetes, which can cause bleeding in the eye, what we call a vitreous hemorrhage, but then also causes kind of glaucoma known as a neovascular glaucoma as well. And also, if you have trauma to the eye, sometimes that itself can lead to cataract and glaucoma and perhaps some retinal pathology as well. In these cases, then we try and address everything at the same time. So you have one procedure where all three things are combined in one go.
Okay, thank you. There's another question. Someone's written, just 1 minute. Okay. Okay, so someone's written, while we have here, so while we're here and giving your comments about the irreversibility of glaucoma, what are the chances of a success of a transplant? Yeah, that's the question.
That's a wonderful question, actually. So with regards to transplant, there's no such thing as a nerve transplant per se at present. Of course, for limbs, they have tried to address nerve issues by connecting different nerves and things like that. But when you talk about the optic nerve, in the nerve that connects your eye to the brain, there is no transplant available for it at present. And because that is the main site of injury in glaucoma, unfortunately, there are no transplant techniques in glaucoma yet. And there's a lot of research happening, and I hope in the future we'll have some treatment options. But there is no such thing at present. Of course, you can have transplant of other parts of the eye. In particular with the eye, the main thing that can be transplanted to restore vision is the cornea, which is the front of the eye. And there can be some conditions where glaucoma is coexisting with corneal diseases, in which case a corneal transplant can restore vision to a certain degree. But for the glaucoma itself, unfortunately, there's no transplant options at present.
Okay. And then someone else's question is, after the surgery to remove glaucoma, does it reoccur? I'm not sure. Yeah, does it reoccur? That's what they've written. Yeah.
So no, and what I often tell my patients is that glaucoma is basically a journey that the patient and I will take together. It's a lifelong process in which intervention may be required at different stages. So we may start with drops. After a few years, maybe the drops aren't working as well as they should. And then another few years later, we might find that the laser treatment has stopped showing its effect. Then we move on to some kind of surgery. And then you kind of keep moving on from there. The aim being to keep the pressure stable throughout your lifetime. So once glaucoma does not reoccur, it may require additional interventions at different stages of your life to keep the vision as optimal as possible.
Thank you so much for that. There's one more. Let me do this question before we go back to more questions. So someone has said that I went to the optician and I was told that my eye pressures were high. Then they referred me to a glaucoma specialist. But when the glaucoma specialist saw me, they did a few tests and said they didn't think it was glaucoma, but instead I had dry eye. Is there a relationship between dry eyes and glaucoma? And I think he's wondering why there was like a discrepancy in the diagnosis. Yeah.
Yes, I know. And it's the question. So there is no relationship between dry eyes and glaucoma. They're two separate things. But one of the great things that our optician colleagues do is if they suspect, they will send you across to your ophthalmologist. And that is the absolutely right thing to do. And then the ophthalmologist might do a few more tests and say that, well, actually, it was good that your optician highlighted this, but in reality, putting it all together, you don't have glaucoma. And that's absolutely fine. And that's something that very often I would do in my clinic as well. But the opticians are very well trained to flag up anything that they may feel is suspicious. It may not necessarily be a condition, but if they feel that there's something of suspicion, they'll send you across. And it's far better to have it checked and have the reassurance than not to.
Okay, and then someone has said, do I get my eye pressures measured by the optician or the ophthalmologist? What is the difference between an optician and ophthalmologist? I think that's a great question, actually.
That is a very good question. So we work very closely with our optician colleagues. The main difference is that our opticians, who are very skilled at what they do, but it is a different skill compared to what we do. So they will basically check your eye for glasses, for contact lenses, and sometimes very specialized kind of contact lenses, and in some cases even low vision aids as well. And that's their area of expertise, and that's what they train for. They have a 4-year degree, they train for that. Whereas an ophthalmologist is basically a doctor and a surgeon. So we are fully qualified doctors, and then we have special training in eye surgery. And so our role is to diagnose any disease conditions of the eyes, and then to give medical or surgical treatment options for that. So the optician is specialized in prescribing glasses to help you see, whereas if there's any disease with the eye, then the ophthalmologist is the doctor who will treat that for you. But both work very closely together.
And another lady said, how about optometrists, please? Like I think there's so many whatever. It's like so many of them, isn't it?
That's true. That's true. Well. Here's the best answer to it. Was basically the optician and the optometrist is the same person.
Good. That makes it easier. One and the same. Good.
It's the same. They're just different countries. They're called differently.
Okay, cool. So if we recap, an optician or optometrist is the one that just does the glasses, does the contact lens, and the ophthalmologist, which we're really lucky to have one in our presence today, is a consultant surgeon and a doctor who's like trained in every disease of the eye. Does that make sense? I think that summarizes it easy for people. Next question is my question, actually. I know we talked about surgery and all the nice things that we're doing with the tiny. Oh, no, sorry, I'm going to stop. So the lady says, aha, really, thank you for this, right? Thank you so much. She's all the way from Nigeria, by the way, and she said, thank you so much for like clarifying this bit. I think a lot of people get confused about the optician and the ophthalmologist, because yesterday I was speaking to someone about this this webinar, and I said we've got this amazing ophthalmologist coming to speak to us all the way from like Dubai, and the person says, oh, but last year summer I was in the UK and I went to Vision Express or something. I said, listen, Vision Express is entirely different from Moorfields. Like, I don't know how to explain that. Vision Express does an amazing job doing like glasses and stuff, but Moorfield is like the guru of eyes, if that makes sense. Like, it's so different. And I was trying to explain it. And I guess as an orthopedic surgeon, it's easier for me to say, I fix bones, I replace hips. It's a little bit difficult to explain to people that your eyes are looked after by different people. And it's just so nice how you put it, and it makes it a lot easier. So I've got another question. What do you do about excess fat prolapse in the eyes? Okay, that's an entirely different question.
Yeah, so this is related to oculoplastics, which is a different subspecialty of ophthalmology. But in effect, the simple answer is that yes, it can be treated surgically. So if you go along and see an ophthalmologist who is specialized in oculoplastics, so essentially dealing with lids and the area around the eyes, then they'll be able to help you with that. But it can be treated, absolutely. And it's not a difficult operation to do, but it's certainly not related to glaucoma.
Yeah, but I do know that the specialists at the Moorfields that can do this for you, isn't it? Yeah, your colleagues at Moorfields, because obviously Moorfields is all about the eyes, and you guys do a lot of like cosmetic things also in Moorfields, isn't it? Right? Like, I guess if you want to get it done, you have to get it done in the right place, and Moorfields will be the place you'll go to. Thanks. So we talked about this beautiful surgeries that we do. And as a surgeon, I'm always like interested in like surgery. And I really like the fact about the tiny thing. I can't stop thinking about it that helps drain all the fluid. I'm just wondering, are there any complications? Obviously there are complications, but are there complications patients should be aware of if they've had to have like glaucoma surgery?
Yes, absolutely. So one of the common figures we quote is that there's a 1 in 1,000 chance that there may be some complication that may require further surgery or could make the vision worse. But if you think about it, 1 in 1,000 basically means 0.001%. So by and large, these procedures are very safe. And I like the way that you put it at the start, is that it's all in comparison to what would happen if you didn't have the surgery. Of course, I wouldn't recommend surgery to anybody if I felt that the risks were not worth it. For example, if somebody has a mild condition, then of course the risk, any risk, is not worth taking. But if the surgery is required, then it is recommended on balance, keeping in mind that on balance, the risk of not doing anything is far higher than the risk of going ahead with surgery. So it's very similar. I often say it's very similar to crossing the street. There's always a risk that sometimes something might happen if we cross the street, but the risks are low, and it's well worth going ahead with it because you have far more to gain than to lose. And that's the only situation in which I would recommend surgery, is when the risks are outweighed by the benefits.
Okay. And I was just going to ask, so if someone did have like one of the, like, let's ask, like someone with mild glaucoma has surgery, how does this affect like their life in terms of when do they get back to work? When can they drive? When can they like look after themselves? Like, I think people want to know these things, like, do they have to like take leave, or do they go to work the next day, you know?
So that is a very important question. Of course, you want to know how it's going to impact your schedules and then how quickly you can get back to your normal routines. So recovery is very quick. With the kind of minimally invasive procedures these days, recovery is quick. Of course, the eye will be a little bit red and a little bit light sensitive for a few days afterwards, but usually we do one eye at a time. So we never do both eyes together. This is for safety reasons. You'd have one eye done, and then a few weeks later, you'd have the other eye. So when you have one eye done, you still have your other eye, allowing you to do everything as normal. For your own comfort, you might take a day or two off work, but by and large, most of our patients are pretty much back to work. I mean, most of us have desk-based jobs these days, unless it involves quite heavy manual labor, which we would ask you to avoid for about a week. But anything else, people are usually back to their work even in a day or two. And then you just have regular follow-ups and some drops to use for a few weeks afterwards. But recovery is quite quick these days.
So they go home the same day, they walk in and they walk out. So it's like a walk-in like clinic, really.
It is. It's day case surgery. In fact, there's our eye hospital, like pretty much every other eye hospital around the world, does not even have inpatient beds anymore because all the work that we do is day case. So you go home the same day, absolutely. You have a bandage on the eye, we take it off the next day, and then you start your drops and carry on with your routine. There are a few simple precautions, like don't get water directly in the eye for a week, don't lift anything heavy, don't bend over for long periods of time. But other than that, by and large, you're back to your normal routine very quickly.
Okay, thanks. So I've got a long question, so I'm going to indulge your patience, right? If a patient is diabetic, was diagnosed with cataracts a few years ago, had surgery, had it and it reoccurred, right? And then they were diagnosed with glaucoma late last year. Is currently using drops and can see a bit. Is he able to move around and is still able to move around the house? But there is a surgery is there a surgery that he can do that will make him better than the eye drops? That's her question. So I think what she's saying is, in a nutshell, is patient's diabetic, diagnosed with cataract, had cataract surgery, now diagnosed with glaucoma, and currently is using eye drops and struggling with vision. Is there something else they can do that is better than eye drops?
So it really depends on how well the pressure is controlled with the eye drops. If the pressure is very well controlled with the eye drops, then carry on with the eye drops. I think that would be the best thing. But if despite the eye drops, or if the eye drops are causing some allergy, some irritation, it's difficult to use, and you want to swap them over with something else. But if the pressure is not controlled with the eye drops, then you have to go ahead with surgery. And as discussed, there are all these different surgical options, some minimally invasive devices, aqueous shunt devices, all of which are available to be provided, absolutely.
Okay, and I was going to say something, right? I know you talked about minimally invasive surgery and the aqueous shunts, right? Are these easily available everywhere in the world, or is it like available in just certain places? Because obviously advancement in healthcare is not everywhere. Is it available like all over the world, or it's not? It's just available. Are there a subset of like specialized people that do these operations, or can any ophthalmologist just do the surgery? I don't know.
Yes, no, they are available very widely around the world. But at the same time, to get the optimal outcome from them, you do need an ophthalmologist who's been trained in them. So I suppose anybody could go ahead and do them, but whether or not you'll get the best outcomes with the experience on how to deal with any complications that might happen, how to ensure optimal post-operative recovery, for that you need a specialist center.
So I think like what we've learned like so far from the conversation, which I think has been really beautiful, because I think even for me, it makes things a lot easier, especially because every time people call me and say you're a doctor, people don't never realize that I might be a different type of doctor and I don't do eyes. And I think
Of
that's
course.
what's important. There's no medical doctor that is like jack of all trades, if that makes sense. And I think for you to get the best for you, then you need to find a specialist that looks after that section of your body that you need to have treated, right? And I think that what we've learned is that one, prevention is key, which means regular health checkups, regular eye check. And then if you're ever going to have anything done, you've got to go to the best place to have it done by the most qualified person. And I think we've been really lucky tonight that the person speaking to us is the most qualified person. And he's done these cases and he realizes and he knows that what to do. And that's the reason why he's really good at his job. It's just like the same. I always say like, the medicine, if you're inside the world of medicine, there's like the Ferrari of medicine and there's like I don't know, I'm not going to say anything, but the other parts of medicine that is not the Ferrari of medicine. And it's good to have the best person treat you. And saying that, there's a question that says, I'm really sorry to ask again. By the way, it's not bad. You can ask as many questions as possible because this is like a huge opportunity to speak to the best person that can treat you. But I just remembered another term. I think this thing about terms in ophthalmology is really a big deal. She said there's someone called an oculist. What is that particular specialty, please? How does this differ from ophthalmology, an optometrist, and an optician?
Yeah, that's a very good question as
So
well. I
many
mean,
words.
keeps it confusing, doesn't it? So
Yes.
an oculist can, in some circles, also mean the same as an optician.
Okay.
So can be the same. Or an oculist can also be somebody who fits, artificial eyes. When somebody has lost an eye and you have a prosthesis to allow for a good cosmetic outcome, that can be an oculist as well.
Okay, cool. Thank you. So an oculist is a prosthetic fitter or like an optician. And then the opticians we know already prescribe glasses, do the lenses, and ophthalmologist is the specialist. Great. So another question says, you talked about the fact that people can have cataracts and other eye conditions existing with glaucoma. If this happens and they coexist, how do you treat them? Do you treat them all at the same time? Or do you treat them in stages, or how does it work?
So usually we treat them at the same time. So if somebody has cataract and glaucoma, rather than subject them to two separate procedures, we would at the same time remove the cataract, and I would at the same time do the glaucoma surgery as well. So in the vast majority of cases, they're all dealt with at the same time. Sometimes you might choose to do them separately, depending on the case complexity, and also depending on the patient preference as well. So sometimes they're done separately, but they can, and by and large, they are dealt with at the same time.
Okay. Thank you so much, Dr. Walker. Another question says, I had cataract surgery a few years ago, and then I've been told recently that my lens is dislocated. Does that predispose me to having glaucoma? Because I do not want to have any more eye surgeries.
Yes, no, it wouldn't predispose you to glaucoma. But if the movement of the lens is causing any visual impairment, then of course the surgeon can reposition the lens for you, but this won't be related to glaucoma.
Okay, thank you so much. I was going to ask another question. When we started, we talked about that a lot of people present when there's an emergency, right? And they can't see, but we didn't actually expand on what are the signs and symptoms people come to you with that are emergency like shows that they've got an emergency and they have like really high pressures and they're at risk of like literally losing their, like seeing 1 second and the next second the vision's gone or something. I don't know whether that happens. It sounds a little bit dramatic, but that's what I was thinking.
It can be, and this is something known as acute angle closure glaucoma, and it's a true ophthalmic emergency in that the pressure in the eye, as we discussed before, normal is between 6 and 21, can go up as high as 50, 60, 70, very high eye pressure, and you get a lot of eye pain with it. So you get a lot of nausea, headaches, vomiting. Typically, the person would be clutching their eye, it's very red, and the vision starts to be mist over very quickly as well. it's very hard to miss. And if somebody's in that state and we check the eye pressure and the pressure is high, then we instantly know that it's a case of acute angle closure glaucoma. And then we very urgently straight away give them some medications, some drops, some tablets, some intravenous medications to lower the pressure, and then proceed with a special kind of laser treatment known as a laser iridotomy to just break that acute attack and settle the eye. And the treatment is very prompt, provided that the patient comes to us straight away. But symptoms are also very noticeable as well. It's not something that a person, if they're undergoing that attack, that they would miss. They would be very aware of it, and they would, in all likelihood, seek treatment straight away.
Okay, thank you so much. And I was going to ask another question. I know we talked about numbers of people, and we keep talking about percentages, and we keep talking about like how bad glaucoma, the outcome is. Like on your practice, like now, like I know your current, when you were like in, let's say like from when you were in the UK to when you were in, like you're in Dubai now, how many people do you see every week? Like I think those numbers are like, how many people do you see every week with glaucoma, that you diagnose with glaucoma? And a second question to that is that when you then see them, what category are they coming in as? Mild, moderate, or very severe? Like what's the majority of them coming in as?
So that's a really good question. So it depends on where I'm working. When I'm working in England, I tend to see more elderly patients, and they would have moderate to advanced glaucoma. But the screening system is very well established in England, so we see a lot of early glaucoma as well. So it's a mix of all three. When I'm working here in Dubai, because as you well know, Dubai is a very expat population. People are moving in and out of jobs quite frequently. So often people will come from different countries where they've already been diagnosed and treated for many years for glaucoma, and now they're under my care. They may already be quite advanced by that stage. But equally, Dubai has a very young and healthy population as well. So in that case, we might see more early cases. But on average, I would say in a week, every day I would see at least 4 or 5 patients with glaucoma. So you can extrapolate that to good numbers over a week and a month. And thankfully, a very small percentage of those are advanced cases. But I have to say that particularly in Africa, the cases of advanced glaucoma are more likely to be 6 to 8 times more likely according to the WHO. And a large part of that is because the screening structures are not in place. And that is why, particularly with this initiative as what you're running, it's very important to increase awareness, because it's with that increased awareness and early detection that those numbers can be improved considerably.
I think that's why we actually do the complete wellness series. The whole idea is for us to make sure that we're talking about topics that people don't think about, right? Because it's a huge cause of blindness, right? And it's irreversible blindness. And I think all you need to do is just have a pressure check, and that could stop you from going blind. And I think it's so sad that, like you said, WHO, when I looked at the numbers with WHO, I was like really shocked. Like it's exponentially too high for 21st century medicine, right? And a lot of people don't understand why, someone just goes blind the next day and everyone's like, oh, why have they gone blind? And everything is attributed to diabetes, but diabetes at least is not the reason. It's just stuff like they just needed that one eye check, that one pressure check, and then hopefully this could have been detected on time. So I think for us, thanks so much for the kind words about saying like the initiative. The whole idea is to get people speaking to specialists and understanding that half of the diseases that happen, or even more than that, like a huge percentage of diseases happening can be prevented. And let's assume they don't get prevented. The more important thing is that you must be treated by the best centers, right? And like I always say, we never think about what we want to do. We like buy nice clothes, buy like through a nice party. But when it comes to health, we're always like, yeah, it's going to be okay. We're just going to keep trotting along. We're just going to keep taking baby steps. And we never think about the fact that health is a huge impact on our lives. And I don't know, I think it's a good point that we're taking out today, that we can prevent this. We can go into 2023 as one of our resolutions with clear vision, because we're preventing glaucoma from happening. I have another question. I know we're running a little bit like out of time, but I just have another question. Does dieting have any effect on the eyes? If yes, what types of food do we need to take so as to put the eyes in a good shape? This is from Nigeria again. Nice question. I love that. Yeah, makes sense.
That is actually a very good question. There have been a few big studies actually looking at that. And what they found was that you need a few specific things for the health of your eye, such as lutein, xanthine, vitamin C, vitamin E, zinc, cuprous oxide, and various other things. And in effect, you can get tablets from pharmacies, multivitamin tablets that that are formulated particularly for the eyes. But more importantly, if you have a balanced, healthy diet, which has a good proportion, a balanced proportion of green leafy vegetables, so like spinach, kale, and things like that, then that is providing you with all these things that you need for the health of your eyes. So if you have a good, healthy, balanced diet with a good proportion of green leafy vegetables in it, then you are getting all that you need to protect your eyes.
So eat right, get your regular eye screening, right? And then go to the right doctors for your eyes. I think that's our take-home message, isn't it? I think.
Absolutely.
I'm going to give people one more opportunity. If you still have any questions, we've only got 5 minutes left. So we've got Dr. Waka for just 5 minutes, right? And after that, I cannot take any more questions. And I was going to say, I know we talked already that there is no guarantee for full recovery. And even though we talk about different varieties of glaucomas that can be treated, and we talked about the fact that the age might be not that significant, but there's something I missed out when you were talking about children being born with glaucoma, right? And I think that for people that like in childbearing age, is there anything that it's related to, like maybe the parents or the pregnancy that predisposes the child to having glaucoma at birth? That's like, I don't know, is there like any neonatal work that's been done to predict that?
Yes, I mean, and then of course, a child being born with glaucoma, that's very difficult for the family as well. But there is no way of, I suppose what you're asking is there a way of predicting beforehand if that would be the case? There is no way of predicting that. And so this is something that becomes apparent after birth. Typically, if there's a lot of tearing from the child's eyes, the eyes look a little bit bigger than they should be, because the pressure is, a child's eyes are very elastic, our eyes are much more rigid in adulthood. And so when we have high pressure, our eyes don't actually change shape, whereas a child's eyes try and adapt to that high pressure by expanding. And so that is a very characteristic appearance with them. The child would be just squeezing their eyes and tearing a lot, and the eye would look bigger than it should. It's this classic triad that gives an indication to the doctor that perhaps there's a glaucoma issue going on here. I would say that reassuringly, the incidence of congenital glaucoma, as we call it, or glaucoma at birth, is very, very low. Less than 1% of cases of glaucoma worldwide are congenital glaucoma. So, but when it happens, certainly we have the expertise in our hospital to deal with it. The same treatment options for adults are available for children as well. And the pressure can be controlled, but thankfully it's very rare. But there is no way of predicting beforehand.
Thank you so much, Dr. Walker. There's one more question. Can optic neuritis leave your eyes damaged? I think the first question was optic neuritis, and can that leave your eyes damaged? Yeah.
Yeah, so optic neuritis is a kind of a demyelinating condition that affects the optic nerve. It basically means that the nerve itself, for kind of reasons within its cellular structure, stops functioning as well as it should do. And it's not related to glaucoma in any way. However, it can cause the same kind of field of vision defects that glaucoma can. And in very severe cases, and this is not common, it can cause a reduction in vision. Usually what happens with optic neuritis is that the vision for about 2 or 3 weeks becomes reduced, and then the body starts to heal itself and it goes back to normal. So this is a condition where there is usually not irreversible damage to the nerve, and it picks its function back up again. Whereas with glaucoma, of course, as we discussed, the damage can be irreversible.
Irreversible. Okay. Thank you so much. Dr. Waka, I think we've taken a lot of your time, and I know, what time is it in Dubai, please? I feel so bad.
It is 11 o'clock at night.
God, it's like 11 p.m. at night. We need to let you go. Thank you. I can't even thank you enough, and thank Moorfields enough for like the knowledge that we've shared tonight. The conversation's been really brilliant. And I think I also want to thank everyone that's joined this call. And this year, we're going to do something a little bit different. And we also want people that are joining to send us topics that they think they want to hear about, especially when it comes to eye care or any other topic at all. But I think when it comes to your eyes, is like a big thing for you to, is there something you're really worried about that you want us to speak about, that you have a few burning questions? So just send that to us also in the chat tonight, and just say, oh, I would like to like have a chat with someone about this or whatever, and then we should be able to like get that done, hopefully. I want to thank Dr. Waka again, right, for your time, because I know you're actually always busy, right? And to get to pin you down to come and do this session has been amazing. And then I want to thank everyone at Moorfield Dubai, Shireen, everyone. I just want to thank you all. Like, it's just been great. You guys have gone far and beyond, constantly like letting us share like the space with your specialists who are like world renowned and really sort of everywhere. They're sought after like everywhere. And I'm really lucky to have you guys here. And obviously my team, you guys have been really great to make this happen. And for everyone, people have joined. I'm just going to do like a shout out where everyone's joined from. I don't know where everyone's joined from. So maybe for some people, if you joined from anywhere I haven't spoken about, please kindly just write that in the chat so I can share. People have joined from Dubai, from Saudi Arabia, from Nigeria, from the US, from the UK. Like I'm just seeing a few names that I know, and I'm just going to shout out to them. And if you've joined from anywhere else I haven't called, thank you so much for being here. Thanks for sharing this evening with us. We've talked about glaucoma, which is the leading cause of blindness in the world. And like the take-home message is get your eyes checked on time, find the right specialist, eat right, loads of green vegetables. I remember that bit. I'm not going to forget that. So get your eyes checked well, eat well, and then hopefully we can prevent this together. And Dr. Waka, before you guys, I just want to do a few comments. People have said very informative. Thank you so much. And the team, great stuff. Thank you too. And thank you. And we're really grateful to have you. Thank you so much.
So it's been an absolute pleasure. Thank you so much for the invitation and to everybody for joining in. It's really been an absolute pleasure. Very grateful that you invited me onto the program today.
Thanks. And someone said next topic. So next topic we're going to have, before we get your topics, we're going to be talking about sickle cell anemia, right? So that's something that is quite rampant in Nigeria and other African countries, and even in the UK. And what we're going to talk about is the new what's available for sickle cell disease. And then we also have a lot of really interesting eye topics that we will also share with you guys soon. But again, if you have anything that you want to talk about in the eyes, please let us know. And everyone said thank you from the team, Dr. Waka. They said thank you so much, Dr. Waka. That's the team. My teams have said that. And everyone else has joined. And someone else says, oh, okay, yeah, we'll talk about other topics. Thank you so much again. And so it's good evening from London and good night from Dubai. And I think from Nigeria, it's still good evening, I think. And then from the US, it's good afternoon, because we've got the team from the US. And I think from Saudi, for the person in Saudi, is good night also. Thank you so much. See you guys next time.
Thank you. Thank you. Take care, everybody. Thank you very much.
Bye. Bye.